Good afternoon, everyone. Welcome you all to today's Indians sessions on brain stimulation module. Today we have with us Dr. G. Venkat Subramanian, very well-known researcher in the field of schizophrenia, transcranial magnetic stimulation. He also has last year won Shanti Swarup Bhatnagar Prize for Science and Technology. It's one of the highest Indian science awards for his contribution to medical sciences. He also has won a DST Swarna Jayanti Fellowship, ICMR's Vidyasagar Award, and DBT Senior Innovative Young Biotechnologist Award, and INSA Young Scientist Medal, ICMR Shakuntala Amir Chand Prize, IPS Young Psychiatrist Award, NASI Platinum Jubilee Young Scientist Award, LCBS Scopus Young Scientist Award, to name a few. Yes, over 370 publications in this field. He is also an editor for Asian Journal of Psychiatry and the Neuromodulation section of
So good afternoon all, and thanks Dr. Chetan for the generous introduction.
So today we'll hear from the wise man about the WISER module. So over to you.
So good afternoon all, and thanks Dr. Chetan for the generous introduction. So looking at certain historical perspective, there's a very nice anecdote which describes somebody stepping over a torpedo fish, which is also called as an electrical ray. That person who stepped over it also had a gout to get interest of several pain conditions like headaches. Fortunately, the science of electrical therapy has evolved beyond sticking a fish to a patient's forehead. And once in the 17th century, the first methods of controllable artificial electricity productions were developed. That led to a series of further inventions which helped in applying electricity in a controlled way to treat several psychological conditions like melancholia historically. If you look at the origins of tDCS, or the transcranial direct stimulation, it has its roots from the oldest form of physical treatment in psychiatry. On the left side of the screen, what we see here is perhaps the primitive version of the modern tDCS, which has now become a pocket-sized equipment. And tDCS is gaining lots and lots of attention with several leading medical journals covering the news items related to its utility. And the basic principle by which tDCS is gaining more and more attention is through the neuroplasticity modulation, and the principle that weak direct current can modulate neuroplasticity is having profound effect in terms of several applications of tDCS. And there is quite a bit of evidence that suggests weak intensity electrical current can indeed have effects on neurons. This is reflected through several lines of research evidence, and they are quite methodologically rigorous studies which has examined a series of techniques, including the neuroimaging techniques which support neural effects of tDCS. There are also basic science studies which are looking at several in vitro models which add further support to neuroplasticity modulation of tDCS. So what is tDCS? That is the transcranial direct current stimulation. It is a non-invasive, safe technique that involves application of low-intensity direct current using bioconducting electrodes placed on the scalp. And this current application leads to polarity-specific neuromodulation and adaptive neuroplasticity changes. we look at the neurobiological effects of tDCS, this is something which is quite critical, especially since it has certain clinical implication. The basic premise is the constant gradient of voltage that is applied through the tDCS. It induces ionic shifts and transmembrane protein changes, which in turn results in changes to optical excitability. This set of schematic diagram which depicts the action potential frequency during tDCS in an experimental setup gives a good understanding about what might be happening. What we see here on the left-hand top corner is the resting state of the action potential frequency. The tDCS, in terms of its anodal or the positive current end, if it is applied to the set of neurons, what happens essentially is this resting membrane potential gets relatively more depolarized. So this is something which is very important to note, because tDCS by itself does not result in a spontaneous action potential or a de novo action potential, whereas it shifts the resting membrane potential to an extent that in turn results in increased frequency of the action potential in those relevant set of neurons. Once the tDCS is switched off, here the anodal stimulation is switched off, the resting membrane potential returns back to the earlier state, and the action potential frequency becomes like what it was before. The reverse happens when the cathodal current is switched on, in the sense the resting membrane potential becomes more hyperpolarized, which in turn leads to cessation of action potential, or the action potential frequency becomes sparse. So that is number one. The second important mechanistic component of tDCS involves neurotransmitter alterations, which predominantly involve GABA and glutamatergic transmission. As we know, GABA is an inhibitory system in general, and glutamate is a facilitatory system. Anodal tDCS inhibits GABA, which in turn inhibits glutamatergic transmission, which in turn leads to net inhibitory effect. The third component involves tDCS facilitating the secretion of certain neurotrophic factors like brain-derived neurotrophic factor, which in turn leads to downstream neuroplastic effects. So there are three important components of the neurobiological mechanistic effect. Number one is dependent on the resting membrane potential changes, with the important emphasis that tDCS by itself does not result in spontaneous or de novo action potential generation. This is important because the risk for seizure as a side effect of transcranial direct current stimulation is extremely unlikely. The other two components of mechanism involves neurotransmitter changes and neurotrophic factor changes. So such effects of the local changes in the neuronal population that occurs due to the surface application of electrodes can get propagated further deeper down, because brain is an interconnected network of neurons, and there are studies that show that superficial cortical modulation can, through network related connectivity alteration, might cause changes in the deeper regions of the brain, as we see here in regions like the hippocampus and parahippocampal regions. We see alterations in the hemodynamics, neurohemodynamics after tDCS. So essentially, the neuroplasticity modulation and its downstream effect is a major component which has made tDCS becoming a center of attention in several neurological and psychiatric disorders. And one such disorder that has been shown to have profound neuroplasticity alteration is schizophrenia. This was a study that was published about 8 years before in American Journal of Psychiatry, where tDCS was shown to result in significant amelioration of persistent auditory verbal hallucination, which indeed made us to get interested into this technique. So the kind of paradigm that we work called as WISER paradigm, which is essentially an acronym that reflects plasticity modulation by a host of brain stimulation technique that apply weak intensity electrical current. And this kind of application offers immense promise in treating psychiatric disorders through, at one level, enhancement of deficient brain functions, as well as amelioration of recalcitrant symptoms, which in turn can facilitate reintegration. So it is weak intensity stimulation for enhancement and reintegration, or the WISER paradigm. And we have been doing several research studies that examine different types of weak intensity stimulation techniques, starting from transcranial direct current stimulation, transcranial alternating current stimulation, high definition tDCS, and there are several other variants like transcranial random noise stimulation, pulse current stimulation. There is an interesting way in which one can non-invasively stimulate vagal nerve stimulation, that is TVNS, and the galvanic vestibular stimulation. Much of our research has focused on tDCS, and to an extent we have started doing work on tACS, and as well as high definition tDCS. There are several other techniques which are in pilot evaluation. We are in the process of launching studies in the related techniques. The presentation today will predominantly focus on tDCS because that is where a lot of clinical evidence is accumulating in terms of translation to the patient applications. So this is the summary slide, which shows several activities that we have been doing with regards to the WISER neuromodulation program in terms of successful implementation of add-on tDCS for treating several psychiatric disorders: schizophrenia, obsessive compulsive disorder, alcohol craving, depression, and across several patient age group. And so what is critical, as I mentioned, in terms of the major mechanistic impact of tDCS is the neuroplasticity modulation. And you look at psychiatry, neuroplasticity aberration is something which is implicated in many of the psychiatric disorders. For some of us to refresh neuroplasticity, molecular and structural features, and we may know this famous statement by Donald Hebb that cells that fire together wire together. And if we look at the neurotransmitter components, it involves glutamate, GABA, and dopamine. And there are studies, some of them which I reviewed in the earlier section, suggest glutamate and GABA related signaling can be modulated by tDCS, and that is where it becomes quite critical in terms of its implication in several psychiatric disorders, including schizophrenia. Our interest in neuroplasticity dates to early 2000, where we reported such a neurotrophic factor deficit in schizophrenia, like insulin-like growth factor and then brain-derived neurotrophic factor, linking such neuroplasticity deficits to the brain structural alterations as well as immune aberration. If we look at the neuroplasticity related abnormalities, as we see in the schema, it may lie central that connects the clinical manifestation to the fundamental aberrations like genetic aberration. And what is important with respect to the neuroplasticity abnormalities is that this is something which is modifiable, and there are a host of interventions that can help us to modulate neuroplasticity, and tDCS is one among them. The reason for me to summarize some of the background work in terms of brain imaging and neurochemical aberration is to tie up the translational application of a mechanism like the direct current stimulation is to an extent informed by the background plasticity abnormalities. And there are similar research works that have happened in various disorders, including, say, depression and several other neurological disorders, where the plasticity modulation is something which is of immense potential, and tDCS taps into it. I'll briefly summarize some of our experiences with regards to the treatment of auditory hallucinations in schizophrenia. We have in the next week the session of tDCS, where we'll be looking rigorously the evidence base, but the focus of today's presentation will be more on some of the fundamental principles that guide these applications. So if you look at schizophrenia, we have two important group of symptoms. One is the positive symptoms, which is associated with aberrant hyperactivation of the temporoparietal junction, and the negative symptom, which is associated with hypoactivation of the prefrontal cortex. So this in some way is a nice situation where we can apply tDCS with the cathodal current, if I may want to simplify, trying to inhibit this aberrant hyperactivity with the anodal current, which may facilitate the prefrontal function. In that sense, tDCS offers a nice opportunity to balance the differential aberrations that we see in the brains of schizophrenia patients. So this is a schematic application of tDCS that we follow for treating auditory verbal hallucination, with the cathodal electrode being placed on the scalp that corresponds to the left temporoparietal junction, and the anodal electrode being placed on the scalp position corresponding to the left dorsolateral prefrontal cortex. The conventional tDCS, that is the tDCS that uses relatively large size electrode of 35 centimeters square, is applied in both these places, which is essentially a bioconducting silicon rubber that is covered in saline sponge, and this in turn is connected through wires to the device, and the current intensity that is given is about 2 milliampere with a duration of 20 minutes. The empirically guided session that we give is for 5 days course of twice daily session with an inter-session interval of 3 hours. So this slide summarizes the initial observations we had in terms of open label study showing tDCS improving the insight of schizophrenia patient with concurrent reduction in the severity of auditory hallucination. And very recently, this open label study we were able to replicate in a randomized sham controlled design, in which the schizophrenia patients with persistent auditory hallucinations were randomized to true or sham tDCS, and we found the efficacy of tDCS to favor in terms of the VRAM or the true tDCS being significantly superior to the sham tDCS. What we also observed in this research to the sham tDCS in the first phase of RCT, that is in this phase 1 of RCT, when they were given open label extension treatment with true tDCS, the improvement in those sham non-responders became much better, like reaching close to a mean reduction of 30% symptom change. What we also see in several of our application of tDCS is that there is significant inter-individual variation in the response. There are certain novel applications in which we can use what is called as a computational modeling to individualize and personalize the neuromodulation. So what we see here is the post hoc simulation of the current intensity spread in a typical responder versus a non-responder. Gross assessment of the brain morphology suggests the non-responder's brain looks much different from a responder's brain. And what we do in tDCS currently is to approximate the placement of electrode based on the 2020 system, which perhaps may not result in optimal picking of current strength in all subjects. For instance, in non-responders, the peaking is much away from the desired region as we compare with the responder. So there may be futuristic potential where we may want to do structural MRI or certain additional advanced image sequences, which can help us to individualize the electrode placement, more so in refined on much more focused techniques like high definition tDCS to optimize the treatment response. So this kind of inter-individual variation has made people to look at what is called as the high definition tDCS or the HD tDCS. This is the slide that summarizes the differences between what is a conventional tDCS versus what is a high definition tDCS. I also want to emphasize much of the clinical work has happened predominantly with the conventional tDCS, especially in psychiatric disorders. The high definition tDCS related studies are emerging, and we need more and more work in this area. In contrast to the large 35 centimeter square electrodes of the conventional tDCS, the high definition tDCS has about 1.2 centimeter diameter ring electrodes. In the conventional tDCS, as you would see, if we have to stimulate a brain region by anodal current, we need to counterbalance it with a cathodal electrode, which means that we have to inhibit some other brain region. So there is no way in which we can either selectively stimulate or selectively inhibit. So this is where high definition tDCS gives a distinct advantage. What is the fundamental principle behind the high definition tDCS is that the placement of the small sized electrodes will follow a ring pattern. We see here 5 different small HD electrodes. The central electrode will be our electrode of interest. And suppose if I'm interested to inject 2 milliampere of anodal current, this will be given in the central electrode. The 4 surrounding electrodes are called as the return electrodes. They will be sharing the return current, the cathodal current of minus 0.5 milliampere. So which offers 2 advantages. Number 1, the current circulation, the circuit completion happens in a very focused region, number 1. Number 2, by dividing the return current, which might be polarity of non-interest, we are able to either selectively stimulate or inhibit a particular brain region, because studies have shown that if an electrode current strength is 0.5 milliampere or lesser, it is unlikely to cause any neuronal alterations. So such high definition application makes tDCS current flow more predictable, and hence it is more amenable for advanced modeling, which in turn can help to implement precise neuromodulation. So high definition tDCS is one technique where there is immense potential available for personalized neuromodulation, which might be a good futuristic direction. So these are some of the simulation studies which emphasizes and adds support to the focality and more predictable current spread nature in high definition tDCS. And there is also some preliminary evidence to suggest that the high definition technique might result in neuroplastic effects that might be potentially longer lasting than conventional tDCS. So we have done some preliminary work using the high definition tDCS in schizophrenia patients with persistent auditory hallucination, where the electrodes are placed selectively in the left temporoparietal junction. As we may recollect, in the conventional tDCS, the cathodal electrode placement of the left TPJ has to be balanced with an anodal electrode placement of the left dorsolateral prefrontal cortex. So this is the way in which the neuromodeling can be simulated and the electrode position can be optimized. And these are currently research applications. And recently we reported significant improvement of auditory hallucinations with the application of add-on HD tDCS, as well as improvement in the insight. This is something which is being done, just being done as an open label observation, which we are pursuing further with a sham controlled study. We can combine the tDCS with the spatial neuronavigation to ensure optimal placement of electrodes, and there are some initial attempts with which we are able to find some interesting correlation between the current application and its improvement, especially with the gray matter volume. There are also certain neurobiological studies that we have done in terms of trying to understand the mechanistic basis of tDCS in improving auditory hallucination. One such paradigm is the corollary discharge. Corollary discharge, as many of us may know, is a mechanism that suppresses necessary consequence of self-generation, and this serves to distinguish between self and non-self. The simplistic description of corollary discharge is given in this schema. Suppose if my brain wants to do a motor act, say for example, picking up a glass of a motor command which goes down through the pyramidal tract, and once the action is executed, there is a proprioceptive input which comes back to the brain. This is called as the reafference copy, which essentially gives us the sense of ownership. There is also another neural impulse that is hypothesized to be generated, which is called as the efference copy, which gives us the sense of agency. So there is a set of neural circuits and regions which basically compare the efference and reafference copies, which is called as a self-monitoring system, which predominantly is linked with the heteromodal association cortices, more specifically in the temporal function, which integrates these two copies of neural signal, and then it generates the concept of self versus non-self. So what happens in schizophrenia is this efference copy is disrupted. Hence, though the ownership is intact, the agency, that is who has initiated a specific action, is disrupted, and that classically manifests as the say the delusions of alien control or several passivity and related Schneiderian first-rank symptoms. So what we did in terms of trying to understand the impact of corollary discharge in schizophrenia is through a simple speech production and monitoring experiment. As we all speak, if we pay attention to what we speak, we will not be able to give a meaningful discourse, more specifically in situations of interpersonal interaction where we have to pay close attention to what is coming from outside. So there is a mechanism which is inherent in the brain which suppresses the brain's responses to the self-generated talk. So what we see here is two different traces. A red line indicates electrophysiological signal change in the sound of talk being fed through a speaker where the person listens to it. So as we would see, the same sound when it is coming from outside will produce a significant N100 signal, which is one of the early auditory processing signal, which shows this particular differential signal change shows that the brain responds differently to self versus non-self stimuli. In people that have auditory hallucination, this kind of distinction between the self and non-self stimuli is lost. In the sense, even the self-generated talk will elicit a significant electrophysiological change, which basically means that a person that has a tendency to develop schizophrenia symptoms will not be able to differentiate a self-generated sub-vocalization from a stimulus that comes from outside. So this is hypothesized as one of the mechanisms of generation that underlies the auditory hallucination. So we did some studies looking at the N100 of self-talk versus the talk fed through an external media, that is talk versus listen, and we were able to replicate the corollary discharge deficit in schizophrenia, and in initial open label design we were able to show that tDCS ameliorates this corollary discharge deficit in patients. Recently, we have been able to replicate this corollary discharge correction of tDCS using a sham control design. And there are also certain resting state fMRI correlates which shows mechanistically relevant brain signal changes, especially involving the brain hemodynamics. And also we were able to uncover the effects of certain medications. That is, there's a patients that had high affinity D2 receptor antipsychotic treatment, say like haloperidol, they responded significantly lesser than people were treated with antipsychotics that had minimal affinity to D2 receptors. So similarly, we were also able to uncover the effects of certain gene polymorphism in terms of the plasticity modulators like COMT and NRG1. So all these studies essentially suggest that the inter-individual variability due to the tDCS can be from anywhere starting with the brain morphology variations to the treatment influences like differential influence of antipsychotic, or it could be due to certain neuroplasticity gene polymorphism differences. But some of the neurobiological studies do support additional evidence through which we can infer tDCS indeed produces pathophysiologically relevant changes in the brain circuits, which can help us to understand at one level tDCS mechanism, at the other level possible neurobiological basis of psychiatric symptoms like hallucination. Coming to the last section of my talk, that is the future direction. Many of these advances may look very exciting and very optimistic. We also need to be fully aware of the daunting challenge. Many of these advances may look very exciting and very optimistic. We also need to be fully aware of the daunting challenge the brain offers. This statement by Lyle Watson exemplifies that. That is, if the brain were so simple we could understand it, we would be so simple we couldn't. So that is something which we have to keep in mind when we are exploring techniques like tDCS, which in my view is still in very, very preliminary stage. There are several factors starting from the socio-demographic factors, starting from the gender, and there are several state level issues like the attentional states. There are several research methods related factors like sample size, experimental environment, and blinding strategies. So there are so many factors which are related to the participants' state as well as the research design issues that may influence the tDCS finding. There are also the brain stimulation parameter specific factors, that is the stimulation intensity, electrode, coil shape, and cytics. So as we see, there are a host of factors that might influence the variability of neurophysiological and behavioral effects in non-invasive brain stimulation. Is something which where we see further rigorosity in improving the studies of tDCS. As of now, we are somewhere here in terms of the tDCS studies, more of a clinical and observatory. We need to combine that with several research techniques as well as concurrently design important behavioral tasks as well as control tasks, which in turn will help us to understand both the mechanism of effect of tDCS as well as the neurobiological aberration in several of the disorders in which we apply, and which can help us to ascend further and lead to a more definitive mechanistic model towards informed application of NIBS techniques like tDCS. Another important advantage with tDCS is because of its portability and safety. there is an immense scope for domiciliary or home-based or remotely supervised application. Of course, we need to replicate the clinic-based studies. We need to complement it with community-based studies and then move this technique to home-based application. But it is quite heartening to know that this is one technique. The tDCS is one technique which, because of its cost effectiveness, has a big potential for home-based translation. So with this, I would summarize and end this session, emphasizing some of the points I tried to communicate. Number one being the weak direct current can modulate neuroplasticity. In that context, I touched upon the basic principles of neuroplasticity, signaling pathways, and then also summarize some of our work on neuroplasticity aberrations in schizophrenia, which contextualizes tDCS as a neuromodulatory technique that can adaptively influence neuroplasticity. Then we briefly touched upon the neurobiological effects in terms of the mechanistic understanding of tDCS that involves the membrane potential changes, neurotransmitter changes, and then the neurotrophic factor mediated alteration. Then we looked at some of the differences between the conventional electrode application of tDCS versus the recent advances in terms of high definition application. Then I tried to summarize some of the neurobiological studies in terms of the corollary discharge amelioration in schizophrenia, before which I summarized our observation in terms of the tDCS application to treat hallucinations in schizophrenia. There is a promising potential for tDCS in terms of its use in pregnancy, children, and elderly, which my colleague Dr. Janardhanan will be covering in the next part of the talk that is in the coming Saturday. And there are also emerging clinical utility of tDCS in several neuropsychiatric disorders, with the major evidence base supporting its application in depression. And then we have schizophrenia, obsessive compulsive disorder, then a mild cognitive impairment, alcohol craving, nicotine dependence, so on and so forth. And there is a futuristic application at one level in terms of replication and enhancing the research rigorosity. Also looking at a personalized application of tDCS through some of the computational neuromodeling techniques. So these are some of the key points I try to communicate. To end, I want to emphasize tDCS seems to be an attractive technique because of its safety, portability, economic viability, and relatively simplistic technique in terms of its administration. While we know that for every solution to every problem is simple, it is the distance between the two where the mystery lies. And as of now, we are still in the very early phase of tDCS, where the distance is still quite a bit to cover. So with this, I wish to acknowledge several of my colleagues that work with me here in the schizophrenia program, as well as a lot of young researchers that work with me here in the translational psychiatry lab. Actually, they are the ones.
Thank you very much, sir, for the lucid presentation. And then ask the question. We have a question from Dr. Rima. Burning sensation is mostly reported by the patient. How to overcome that?
Yeah, I think first is we need to ensure that the saline is of optimal concentration. I think 10 millimolar saline should be good. And then we also need to ensure that the local lesions are not there. And the third aspect is generally the burning sensation will be transient, and it perhaps should subside after about 2 to 3 minutes of stimulation. The fourth aspect is, in case despite all these aspects, we still have the patient complaining significant burning sensation, Instead of 2 milliampere, there is an option to consider relatively lower strength, that is 1.5 milliampere. And sometimes in exceptional patient, you may want to even use 1 milliampere, essentially because the inter-individual differences of the current conductivity as well as the skin sensitivity. So with these strategies, most often we are able to handle the burning sensation, and it has not led to cessation of any sessions in terms of our experience here at NIMANS.
Sir, tDCS approved, is it approved method for general public?
General public means people that do not have any disorder, I assume that. It is not approved for use in healthy population. It's used in people with disorders in terms of psychiatric symptoms or neurological symptom, is still, I would say, in an experimental mode. So the guidelines-based approvals are emerging. Say, for example, to an extent, evidence base is available for its application in depression, and it is increasingly available the evidence is increasingly available for its utility to treat persistent auditory hallucinations. Beyond that, as of now, we do not have robust evidence for generic application of tDCS in other situations. So we have to consider offer of tDCS mostly as a case-by-case basis, in which we carefully look at the available alternatives and choose tDCS and have enough justification to go ahead with them. Can ECT and tDCS be combined is another question. There is one publication that has looked at the potential beneficial effects of combining tDCS and ECT. This is from Colin Lu's group, and it has not shown definitive support towards combining it. There are emerging studies which are still happening. We need to do more work in this area. Though it seems to be an attractive option, as of now, there is no pressing evidence to support that practice. So it has to be more to be pursued. Yeah.
For depression, ketamine versus tDCS.
So for ketamine versus tDCS, I would say that ketamine's role in treating depression is becoming more applicable in treatment-resistant depression, whereas the utility of tDCS in treatment-resistant depression is very less. Studies have not supported its beneficial effects in treatment-resistant depression. There are no comparative studies that have looked at head-to-head trial of ketamine versus tDCS.
If participants don't have a question, I have a question, sir.
Yes.
Like RTMS, the newer tDCS, the HD tDCS, also can differentially inhibit and differentially stimulate different brain areas. So does that also mean, like RTMS, this can also be used for, say, negative symptoms in schizophrenia, or even, say, for example, to improve cognition in schizophrenia?
Yes, there is a scope that's a good thought in terms of its application. Yes, the differential stimulation in terms of polarity offers that opportunity. There are existing studies that have looked at even with conventional tDCS, negative symptoms could be improved. There are studies that have shown in a sham control design, which Dr. Janardhanan will be covering in the next talk. Similarly, for cognition enhancement also it has been shown. But as you rightly focused, the high definition tDCS will help us to give a differential neuromodulation of selective polarity.
How frequently we can give tDCS to patients?
The generally applied frequency is 1 to 2 times a day. Most of the studies have looked at continuous or repeated application in a continuous course over a period of 5 to 10 days, that is 1 to 2 weeks. And there are few studies that have looked at relatively longer term application, that is 3 to 4 weeks. And there are handful of case reports that report long-term repeated application of tDCS ranging from few months to up to 3 years. So there is a wide range of frequency that are being used, which is largely empirical, and we need more research in this area to choose the frequency and the duration on an informed basis. But it is suffice to say that some of these empirical application indeed has been found to be helpful in these studies, and slowly they are moving towards clinical practice, at least in the context of depression, with the relatively more evidence that is available.
The longest duration of hallucination remission?
It varies from patient to patient, and we have patient where the improvement, once it had happened, they came back within a week's time, to very few patients in whom the hallucinations remitted for close to a year's duration. So yeah, so these are issues which we need to explore further and see what determines the persistence of remission, and what are the patient population where we need to give repeated courses of tDCS, which we also call as booster sessions of tDCS.
We thank Dr. Venkat Subramanian sir for his time for us, and we also thank all the participants who participated and asked the questions.
Yeah, thank you.
Not the least, we also would like to place our sincere thanks to the Linux Laboratories, Chennai, for their support through educational grant.